Before proceeding to last talk, I want to mention that if you have any question, please write down on the paper along with your name and submit it towards the IT. That will be asked in last. So today's last speaker of our session is Dr. Kamran Sadiq. He has done his fellowship from the British Columbia in the Pediatric Gastroenterology and Hepatology from the British Columbia Children's Hospital, Vancouver, Canada, and currently he is a assistant professor at the Aga Khan University Hospital. So, sir will talk about the fatty liver disease in the children.
Thank you, Arif, for the kind introduction, and thank you to the organization of this conference for inviting me for this talk. Today, I'll be talking about the question whether to call NAFLD or to label MAFLD in children. I don't have any financial disclosures, but I have to declare that quite a few of these slides are taken from the slide deck of easel. The outline of today's talk, I'll be talking about two cases, then talk about NAFLD, what's definition, is it a problem of Pakistan, what's the background, pathogenesis, natural history and treatment. Then few slides about the guidelines from North American Society of Gastroenterology. Then we'll go to MAFLD and then back to cases. So first case. So this was a 15-year-old kiddo who was sent to us with complaint of recurrent abdominal pain. His BMI was 27. General physical examination was normal. They bought a stool test, which is stool H. pylori was negative. His ALT was elevated with a normal bilirubin. Fasting triglyceride was 181. Ultrasound abdomen showed fatty liver. And when we talked to the family that we need a liver biopsy for the diagnosis, the family refused. So we thought this could be non-alcoholic fatty liver disease. Second is an interesting case. This was a 13-year-old girl, quite healthy looking. The family was very surprised that our girl likes to eat a lot. He's very healthy, drinks about 2 liters of milk in a day, but still feels tired the whole day. Her BMI was 28. On physical examination, the liver was palpable. She had some iron deficiency anemia. ALT was again elevated. Ultrasound abdomen showed fatty liver. And when we told our family that we need to do more investigation and said, हमारे बच्चे का बहुत टेस्ट कर लिया और नहीं टेस्ट करो, खून ही खत्म हो जाएगा. Anyways, so we don't have a fasting triglyceride on this kiddo, and we don't have a liver biopsy on this kid. So what to do? We'll see. So what is NAFLD? The pediatric definition of non-alcoholic fatty liver disease, it's a spectrum of liver pathology ranging from isolated steatosis to steatohepatitis to cirrhosis in the absence of infectious or autoimmune etiology. While metabolic associated fatty liver disease does not require exclusion of other etiologies like viral hepatitis or consumption of alcohol. Let's just first talk about NAFLD. What's the background? So pediatric NAFLD is a pretty common disease in the Western world. Its prevalence is about 9% in the US population, and it's associated with early onset type 2 diabetes, mellitus, dyslipidemia, early onset hypertension, obstructive sleep apnea, and psychological issues in the school performance. So why should we care about NAFLD? हमारे बच्चों में तो अंडर न्यूट्रिशन कॉमन है, obesity तो है ही नहीं. So this is a picture from the Pakistan Demographic and Health Survey, and it shows that about 10 to 20% of kids are underweight, but there is overweight and obesity is also common in our part of the world. Then another question, कि ठीक है obesity होगी, but ये तो शहरों में होगी ना. हमारी तो majority population गांव देहात में रहती है, वहाँ तो पैसे ही नहीं, लोग गरीब होते हैं. The same service tells us that the prevalence of frank obesity is same whether it's rural or urban population. So NAFLD is quite common in our part of the world, and especially during the last few years after COVID. साढ़े 5 साल के 6 साल के बच्चों को पता है कि फूड पांडा से कैसे ऑर्डर करना है, and then we have obesity at our hands. So when to suspect pediatric NAFLD? There may be clinical suspicion, and then there are some confirmatory tests. So the patient may present with recurrent abdominal pain, they may present with excessive tiredness, examination may show hepatomegaly, labs would show increased ALT and triglyceride. Unfortunately, AST and gamma GT are not used as a screening tool in children, and ultrasound will be abnormal. The only confirmatory test for kids is liver biopsy, which should show more than 5% of hepatocyte involvement with steatosis. We pediatricians don't like to do CT scans, so we don't have enough data because we are concerned about the cumulative effect of ionizing radiation. MRI data is also limited. Problem with FibroScan is that we don't have age-related normal data, so FibroScan cannot be used for pediatric age group as well, and biomarkers are still in the pipeline. So how do we develop? What's the pathogenesis? So we start with high caloric intake, then excess intake of saturated fatty acid, high fructose intake, sedentary lifestyle, and if this continues, leads to obesity, and then to NAFLD. There are a few genes that are associated with early onset NAFLD, and this is very pertinent to our part of the world because we have a very high risk, high consanguinity. So congenital diseases are common in our part of the world. What's the natural history of NAFLD? So if someone has steatosis and it remains untreated, it progresses to NASH, then to advanced fibrosis, cirrhosis, and then there is always a risk of hepatocellular carcinoma, liver failure leading to liver transplant, or if the liver transplant is not available, to death. What are the treatment guidelines for NAFLD? It starts with the diet, disease starts with the diet, and treatment also starts with the diet. We have to change lifestyle modification, and about 7 to 10% weight loss is associated with recovery at the histological level, not just the outside looking, but at the histological levels as well. Second thing to do is exercise. Diet and exercise combined can greatly change the outcome of patients with NAFLD. The choice of training, what dietary exercise should be done, or what exercise should be done, have to be tailor-made, but depending on the patient's preference. What are the components of lifestyle approach to NAFLD? First, energy restriction. So the target is 7 to 10% weight loss, and this should not be just short-term weight loss. We have to have a long-term maintenance approach. Drinks with high sugary content, we should avoid those. There was a concern about caffeine and association with liver disease, but to date, there's no confirmatory data supporting caffeine consumption to liver pathology. Alcohol, luckily, this is not a pediatric problem, but alcohol reduction intake should be reduced. Then comes dietary modification. Low fat diet, then moderate to high carbohydrate, and there is also a role of ketogenic diet with high proteins in the management of NAFLD. Physical activity, it should be sustained physical activity, almost minimum 3 to 5 sessions in a day, in a week. And strenuous resistance training will promote not only musculoskeletal fitness, but also improve metabolic factors as well. When to use drugs in the treatment of NASH. So drugs are used when either we have tried dietary and exercise modification and that have failed, or when the patient has progressive NASH at presentation. So it should only be reserved for F2 or higher stages of fibrosis. What drugs can be used? Insulin sensitizers are the first line drugs, not the first line, but important drugs, and they can achieve histological remission in NASH. Antioxidants like vitamin E improve steatosis, inflammation, and ballooning, and resolve NASH in some patients. When we start drug, then there is always a question when to stop drug. So the recommendation is that we try these drugs for 6 months, and if we don't find any change, any reduction in the aminotransferase levels, then we think of stopping the drugs. Even though when you do laboratory work, you see elevated triglyceride levels, but statins have not been adequately studied and don't have a beneficial effects in treatment of non-alcoholic fatty liver disease. So what are the NASPGHAN guidelines? NASPGHAN has 7 steps in the guideline for management of NAFLD. First step, how often should we follow up cases? So it is recommended that every 6 months to a year, these patients should be seen back in the clinic, and during these visits, we have to monitor disease progression and compliance to treatment. Second step in the management is nutrition. So weight reduction, limit sugar sweetened beverages, but what specific diet to offer, there is no consensus because kids need to grow. So we are not sure to how much low fat diet should be given, but physical activity is the key. Decrease the amount of the nutrition and increase physical activity. At least 40 minutes of activity per 5 days in a week is recommended for treatment for NAFLD. Medications. Current guidelines do not have any recommendation for pediatric treatment of NAFLD. Drugs which have been studied for adults, vitamin E, metformin, and fish oil, have not proven benefit in treatment of pediatric NAFLD. Then comes the roles of surgery. When should we think of surgery? If the child has morbid obesity, the BMI is more than 35, and we have the dietary and exercise measures have failed, then there are recommendations that these kids should be referred for pediatric bariatric surgery. We should always screen for comorbidities like dyslipidemia and type 2 diabetes. Every child who comes to the clinic should have his or her blood pressure monitored, because those kids who have higher blood pressure have the worst steatosis. What are the goals of treatment for pediatric goals for treatment of NAFLD? So first one is regression of NAFLD. And how do we measure that? We take decreasing SUPT as a surrogate marker. Unfortunately, we can't offer repeated liver biopsies. Ultrasounds for regression of disease is not reliable. CT and MRI have not been studied in pediatric age group. And like I said in my previous slides, we have limited data about fibroscan. So all that's left is to do see decreasing ALT or repeat liver biopsy. So now let's come to metabolic acid associated fatty liver disease. Why this new term was coined? So this is the adult data. The 40% of cases with NAFLD were non-obese, and of these 40%, half of them were lean. So there was a thought that there must be something else that's going on. The other thing is that many patients with NASH develop hepatocellular carcinoma, and especially diabetics are at high risk for hepatocellular carcinoma. So hence, this new diagnosis of metabolic associated fatty liver disease was made. And this diagnostic criteria was suggested. So any adult with which has steatosis on imaging technique, blood biomarker, or liver histology, who has obesity, we label them as MAFLD, or steatosis plus type 2 diabetes, again MAFLD. Those who don't have type 2 diabetes and are of normal build, then out of these 7 criteria, I'm sorry, this slide may not be properly visible. So, so we take waist circumference, we measure blood pressure, check plasma triglyceride level, plasma insulin resistance, and do the pre-diabetic screening. And out of these 7, if 2 are positive, then we label them as having MAFLD. So in summary, what's MAFLD? Non-alcoholic fatty liver disease is associated with obesity, with the excessive alcohol consumption, and when we have excluded other causes of liver disease, while metabolic fatty liver disease is when we have evidence of metabolic regulation and type 2 diabetes. So now comes the question of my talk. What term should we use in our patient? So we go back to the cases to answer this talk. We don't have enough data to label these kiddos as having fatty liver because we don't have a liver biopsy. So most probably labeling them as having metabolic associated fatty liver disease would be a better thing. Similarly, for the second case, we don't even have a fasting triglyceride on this kiddo. So, but we have elevated ALT, high BMI, and liver is palpable. So most probably this kiddo has metabolic associated fatty liver disease. Thank you.
Thank you, sir, for providing detail about the newer terminology used for the fatty liver disease in the children. Now, coming toward the question answer session, first question from the first talk from Dr. Anjum Saeed by the Dr. Altaf Alam Saab. Have you ever used adivexibate or miralexibate if available for the cholestatic syndrome in the pediatric population? Are these newer drugs are available and have been used or brought from abroad, sir?
So these medications are just marketed in North America and Europe in 2021, but we do not have the availability in Pakistan. They are being used in pediatric age group, and there are studies that they have seen that the bile acid concentration after using this medication has dropped down significantly, and there was improvement in the pruritic score. Each score was documented in the literature.
Professor Altaf, we do have 2 children on Bileway in Pakistan. Both have ABCB11, which is not this. It's not indicated in the severe ABCB11, in the ones which actually are not that bad but have very bad pruritus. but these parents actually reached out. We are now in negotiation with the company, and then hopefully, because we want it as an orphan drug in charitable access program like we get for other patients for tyrosinemia or for lipid storage disorders. So we are in negotiation with them, and we might be able to get for 6 patients next year. At the moment, there are 2 patients on Bylvay, and they're doing really well. The pruritus is gone. They're sleeping well. So if you select your patient well, you might. That's the importance of this drug, to use it in an appropriate setting. We can't afford the price because the drug is so expensive. But the thing is, just like the other drugs, the orphan drugs which we get across in Pakistan, every orphan drug company is obliged to give a small percentage of it to the developing countries where the patients don't have access. We make use of that law, and we are getting in Children's Hospital. I'll give you a rough estimate. Pediatric hepatology department gets across drugs worth $20 million every year, totally free of cost. But these are all on charitable access programs, so for different indications. In the same way, we have approached the company. They're presently holding a series of workshops with the patients community and with us to, they have done about 6 over the past 2 months in order to understand. Once we make them understand, we will get the drug across. But it's so important because we are transplanting everybody for sometimes even for the sheer debilitating pruritus, which disturbs their life, and they actually don't have liver failure per se. So if we leave aside the very bad ABCB11 mutations, which will require a transplant anyway, and they won't do well with diversion even. Despite diversion, some of them are bad pruritus and they are candidates for this drug.
So, second question from Dr. Shamama Hassan by again Dr. Altaf Alam Sahab. Role of N-acetylcysteine, IV or even oral via NG in non-paracetamol induced liver failure. Mike.
Thank you very much, sir, for your question. So according to our experience in the pediatric population, I know Prof is a bit person to answer this, but it is not of a huge significance as far as the children are concerned in the non-paracetamol poisoning patients. So really not of significance.
Okay. So third question from Dr. Kamran Sadiq sir, regarding your case scenario that why the gamma GT level, AST level, and triglyceride level were not available for that child.
So this is the common scenario for pediatric when we deal with kids. When you ask parents that आज हमने ये टेस्ट करना है, कल दूसरा टेस्ट करना है, it's very difficult for the family to agree to a second blood draw. So that was the reason that we don't have triglyceride level for the second kid.
Thank you. So now it's time that I would request to the chairs kindly give your comments regarding our today's topic and today's session regarding pediatric hepatology and discussed on the various topics.
Thank you, Arith. Thank you, first of all, to Pakistan Society of Hepatology for inviting us and having a pediatric session this time. Thank you very much to all the organizers. This has been my request for quite some time, and I really, really appreciate it. And I think a lot of people worked together to put this into a reality this time and gave us a slot. We do believe that pediatric hepatology is so important because a lot of the adult colleagues of mine do see pediatric cases, especially teenage and sometimes even the younger ones. So it's important to understand the diseases which are relevant to the pediatric population. And the first paper highlighted that. Dr. Anjum spoke about pruritus and the itch and the jaundice, which he was actually referring to the majority of the genetic cholestatic disease that we see. We do see a fair amount of acquired diseases like the adults when you have obstructive liver disease and pruritus, but that was not the point of the paper. So I think this has been the benchmark of research in pediatric hepatology, that as we discover more and more into the cholestatic syndromes of pediatrics, because it has been central to the development of pediatric hepatology to understand the genetic background of cholestatic syndromes. Once we understand more and more, the neonatal idiopathic hepatitis, as we used to call it, is almost become extinct, and we hardly may have just a few percentage of patients that we don't attach a label of diagnosis when you have an infant with jaundice or a newborn with jaundice. So in this context, we already discussed about the various options of treatment, but I think it's very important for our adults and all the colleagues who deal with an infant with jaundice or he's got an itching, is that this patient requires a genetic study or requires a PGI consult. Early diversion surgery in our low gamma GTP FIC is really life-changing for them, and we have seen in our commonest mutations that we have, which Anjum presented, the ABCB11, you do a biliary diversion early, it changes the life. Yes, a small percentage of them, despite early diversion, may still go towards transplant, but if we do a diversion in the majority, we can hold on to the transplant for much, much longer. And the child can be older and can have a transplant, and some may, we don't even know, may never require it for some decades. So it's very important, and the new drugs which are coming up, and we are bidding for them because they're going to be the game changers, literally, which Professor Altaf Alam was highlighting. They're the game changers for us, particularly in pediatrics, because they're going to be the life-changing drugs for pediatric population, where you see severe pruritus is one of the reasons for transplant. Thank you, Dr. Anjum, for presenting the data, and Dr. Salman highlighted a similar thing, neonatal cholestasis, which is an important issue in pediatrics. Many of the things will be almost the similar ones as Dr. Anjum highlighted. A very interesting paper discussion presentation by Shamama. Though Shamama, I would have wanted you to mention about the non-A to E and the ones which we are also facing, just like the rest of the world. Post-COVID, a lot of pediatric patients with acute liver failure of unknown etiology, and Children's Hospital is seeing that. We recently gave our data to the King's College and the European Consortium for Liver Diseases because they wanted to look at it. And I think adenovirus, as you're aware, is considered to be one of the infective agents, but we really don't know much about it still. In Pakistan, we still don't know much about the acute liver failure etiology. If we leave aside the genetic causes, when we talk about acute liver failure, which is non-hepatitis A or B or E, we are really stuck with diagnosis. If the Wilsonian failure we have started to recognize and might require a transplant, but here we are stuck also with when we have such a patient, many of the centers which don't have the transplant facility in them are losing these patients because they really should be in a transplant facility in order to get an optimal management. And even despite a transplant, they might not have the same outcome or prognosis as another patient with liver disease. So we lack on our data, we lack on our management options of acute liver failure in pediatrics at the moment. And thank you very much, Dr. Kamran, for highlighting a very important issue in pediatrics, because if somebody was to ask me that from the non-communicable disease point of view, what is the most pressing thing, and I would say one of them is the NASH, because we see so much NASH in pediatrics now. I agree with with Dr. Kamran that this is more of a metabolic fatty liver disease, and really calling it non-alcoholic doesn't make sense in pediatrics. So, so we could say this is a metabolic fatty liver disease. But this was highlighted first of all by a lot of transplant centers, that young men in their 20s, when they were going across to India for transplant as donors, they were taking their relatives. So the centers there pointed out to me that, Huma, आपके मुल्क में क्या हो रहा है? आपके young 20s में लड़के और लड़कियां, they're having a lot of fatty liver disease, and they are being rejected as donors. And then we saw it in our own centers, where young men and women are being rejected as donors even though they may not be that obese. So I think working out the reasons and lifestyle modification or the dietary modifications which are needed in your country, this is very much the discussion. This should be a discussion of the day. Why are our children getting fatty livers? And so obesity is one element, but there must be other elements. We did do a study. We have started studying the genetic the reasons. We haven't found a whole bunch, but we did look at the PNPLA3 gene, which is fairly common even in Pakistan. But then that's not the only reason for the fatty liver disease in Pakistan. So I'll give over the mic. I think my colleague on the left and right side would like to say something. And thank you once again to the society for inviting us, and to the speakers especially who gave such excellent talks. Thank you.
Thank you very much. I think as far as the last point that you raised, Huma, about why do we have so much of fatty liver, and metabolic was referred to, although we don't have data, but my feel is, and I think strongly we should look at the way we have changed our eating habits, the kind of foods that we use, and the kind of foods that our children are getting. And certainly along with that, the lifestyle in terms of activity. These two things, I think, if we ignore, we are ignoring a lot of it. But otherwise, you have made comments that I would agree with, and thank you very much for putting those comments. And certainly, generally, children grow into adults. But when it comes to medicine and the medical field, adults grow into children. So we have to really depend so much onto the adults' data and their experiences. Then we can only handle the children accordingly. So I think it's a great sharing of information that we have to field on pediatric side, and then also we enjoyed presentations this morning and all day long. The Pakistan Society of Gastroenterology, which is due, I think, a few months down the road, used to have pediatric sessions in early 90s and up to late 90s. And I think it's a very welcome change that PhD also is starting with the pediatric session. And I must thank the organizers and the PSH for holding this pediatric session, and appreciate all the speakers as well as participants for this session. Thank you very much.
Thank you very much. All the presentations were very nice. Taking the advantage of this platform and the presence of the thoughtful and influential people present here, I would like to mention in practice. As pediatric hepatology and liver transplant is evolving, it's a time to take serious action about that problems. The genetic testing and metabolic workup, they are much important in pediatric hepatology and liver transplant. And the problem is their availability and cost. On behalf of liver transplant team Gambard, I acknowledge and appreciate the unconditional support of Madam Huma. She provided us genetic testing free of cost for the last 4 years. Thank you, ma'am. I request you all to please clap for her. It's a time that we must have some efficient genetic labs in Pakistan. I think Madam will tell us that she used to send these tests for genetic testing abroad. Definitely it takes some time. For the selection of donor from among blood relative, it's very difficult for us to choose the right one as a donor. So the availability of efficient genetic lab in Pakistan is very important. Number two thing, the metabolic workup. That is very, the metabolic workup is very lengthy and costly. Most of our patients, they lost their follow-up because of financial constraints. As right now in 2 provinces, this health card system is applicable. So my request is to our influential people to please include this metabolic workup, at least in these provinces, KPK and Punjab, to include this metabolic workup in health card. And in the area where this health card is not functional, like in Balochistan and Sindh, in that area, the resourceful person in the coalition with the diagnostic industry, they may provide these metabolic panels on subsidized rate for the poor population, poor patients. And at the end, as Dr. Kamran reinforced the importance of this obesity in children, I would like to tell you that these burgers and pizzas and unhealthy lifestyle, this is making our children chicken, and this one potato and two potato like things, they making our children potato. और आप सब लोग जो एडवर्टाइजमेंट होती है, जो एड्स होते हैं, उनकी इंपॉर्टेंस के बारे में जानते हैं. जब हम एक टीवी पे ऐड देखते हैं कि एक एथलीट अपनी विक्ट्री की सेलिब्रेशन कोका कोला पी के कर रहा होता है, या आफ्टर स्टर्नस एक्सरसाइजेज वो अपने माथे का पसीना कोका कोला से साफ करके पीता है, तो मेजॉरिटी लोग ये समझते हैं कि इसकी स्ट्रेंथ और इसका जो स्टेमिना है, द कॉज इज कोका कोला. इसी तरह हम देखते हैं कि एक हीरो सिगरेट का कश लेके कोई डायलॉग बोलता है, तो हम समझते हैं कि शायद इसकी बहादुरी की वजह ये सिगरेट है. तो जब ये बुरी चीज़ें इन एड्स की वजह से एक इम्पैक्ट रखती हैं, तो क्यों ना इस एडवर्टाइजमेंट वाले प्रोसेस को हम अच्छी चीज़ों के लिए इस्तेमाल करें. और उसका क्या इम्पैक्ट होता है, वो आपने कुछ ही अर्सा पहले रोनाल्डो को देखा होगा अपनी प्रेस कॉन्फ्रेंस में, उसने जस्ट एक कोका कोला की बॉटल को चेंज किया था वाटर बॉटल के साथ, तो दुनिया में तहलका मच गया था. तो आई रिक्वेस्ट एट दिस प्लेटफॉर्म एट PSH, दे शुड allocate some money for advertisement, the awareness ad, or to run it for a year regarding healthy lifestyle and avoidance of these fast food and beverages. One ad, 1 year by PSH. I suggest to act on that. Thank you very much.
So in the end, I would like to thank organizing committee, my honorable chairs and precious speakers, and all participants. Thank you. Thanks a lot for patient listening.
Thank you, Anna. Nice of you.
We actually have started a foundation for genomics and genomics research. यहाँ पे हम low profit पे we have started with some common